Good morning, everyone. My name is Maya Luria with TMC for Seniors, and today we are going to be talking about fragility fractures. As everyone knows, September is our fall prevention month, so this is a really important topic to learn more about our bones and how we take care of them. So I have Dr. Brianna Patti here with me today. She is with Tucson Orthopaedic Institute. And I just want to share with you a little bit about her. We do have an in-person audience along with our audience online. So please leave any questions for Dr. Patti in the comments if you are part of our online audience, and she'll answer those at the end. Dr. Patti is a fellowship-trained orthopedic trauma surgeon, and she also is trained as a generalist, which means she can do the vast majority of orthopedic injuries and issues. She received her medical degree from the University of Colorado and completed her fellowship at the University of New Mexico Health Sciences Center, Department of Orthopedic Surgery. So I was talking to Dr. Patti earlier. She was telling me how really she does trauma. So, you know, if you fracture something, that's who you want there. So I want to welcome you, Dr. Patti. Thank you for being here today.
Thank you. Thanks for having me. Again, hi everybody. Nice to be here with you this morning.
All right, so I'll go ahead and put your PowerPoint up and we'll let you get started.
Okay, all right. I'm gonna keep my little stopwatch here. Sorry if you see me looking down. It's not me actually like sending text messages. It's making sure I stay on time for you guys. Okay. All right, let's make sure this guy's working. All right, well, good morning, everybody. I know I've said that like 4 times already. So this is the talk about fragility fractures. Thank you all for being here this morning. As Maya said, my name is Brianna Patti. I'm one of the newer surgeons over at TOY. My office happens to be the TOY East office, which is right here hooked on to TMC, so right around the corner, so close I walked over here from clinic this morning. And as she said, I'm fellowship trained trauma surgeon. Fractures, broken bones, things that don't heal in the proper spot, don't heal at all. Those tend to be the patients and the fractures and cases that come to me. Like she said, my medical training was at the University of Colorado in Denver, which is where the M-Shoot Center is now. And then did my internship and residency at the SUMA Akron City Hospital program. For anybody who doesn't know where Akron, Ohio is, it's just a little bit south of Cleveland. It is the world headquarters of Goodyear and the hometown of LeBron James, if that name sounds familiar. And then circled back around to the Southwest. I am a Southwest kiddo by birth, and so I did my fellowship training just one state to the east of us in Albuquerque, New Mexico. I practiced up in Flagstaff for multiple years and then came down here, and now I'm in Tucson. So it's a little bit about me. All right, I have no disclosures for this talk. I'm just here to give you an overview of fragility fractures and talk about some things related to that today. So goals for today. Anytime I ever gave a lecture as a resident or fellow or went to a conference, this was always one of my key slides that I paid attention to or made sure that I made. If we can get through the 80 plus slides that I have for this less than an hour talk, what things should you take away from this talk? What talking points do I want you to leave with? And here they are. So the first 2 are just be able to define and describe. We're here talking about fragility fractures. What the heck is a fragility fracture? Is it just one kind of break? Is it in one particular bone? Who gets these things? What is the definition of a fragility fracture? The second thing to talk about is actually osteoporosis and osteopenia, which is very closely related. You'll see that fragility fractures and osteoporosis kind of go hand in hand, so you can't really have a good definition of one without the other. So we'll go over that. Then the other 2 big talking points and goals for today are, number 1, to answer the question, what does it mean to have a fragility fracture? Well, it's just a broken bone, right? It heals all the time. I'm good to go in 6 weeks, no issues, right? Wrong for fragility fractures. And so we're going to talk about some of the actual consequences of ending up in the ER with one of these and having to see me or one of my partners and get these things fixed. And then the last and maybe even the most important point for today is, okay, I've kind of been drinking the Kool-Aid. I hear what you're saying. what can I do to prevent a fragility fracture? Is it just a foregone conclusion that I'm going to have one of these things, or can I do something now to prevent having one of these down the line? And we'll talk about that. That will be at the end of the talk. I do want to preface this entire lecture by saying this is a massive, massive, massive topic. There are week-long medical conferences dedicated to this entire topic. So there's no way that I'm going to be able to cover every single little detail for you guys today. We're kind of going to take an overview, look at the whole forest, the entire kind of fragility fractures bundle. We may not be able to go down each individual tree, so to speak, detail-wise, but I'll try and answer as many questions as I can. And again, try and give you a good working overview of everything that we need to know here. All right, here we go. So first point, what is a fragility fracture? What are these things? So the fragility fracture definition is a fracture, which is a broken bone. Fractures and breaks are the same thing. That nomenclature is used interchangeably, okay? It's a fracture of a bone after a low energy event. And there's what's described as the underlying deterioration of bone mass and microarchitecture that makes that particular bone more susceptible or more likely to have a fracture. Okay, that's still a bunch of medicalese and jargon. I'm never going to be able to repeat that to anybody. What does that mean? What it means is, and the basic way to think about this is, oh, come on. I think we're stalled here. Yep, so bones that don't break do break. So if you were in your 20s and 30s, someone who has perfect bone microarchitecture, no signs of osteoporosis or bone weakening, it would take a 300-foot fall down the side of the Grand Canyon. It would take a car crash on the highway going 120 miles an hour. And instead, that same fracture, that same high energy look to the breaks in the bones and the fracture patterns we're getting these from ground level falls, trips and slips from your foot being level on the ground that you would have been able to get up and walk off, not think twice about it decades ago. Now it's causing a fracture and a broken bone, okay? And again, these bones, why do they break like that? Well, it's because they're weaker than normal. And the vast majority of the time, with some rare exceptions, that weakness is usually due to osteoporosis. So you can already see osteoporosis and fragility fractures very much go hand in hand with each other. You kind of can't have one without the other, so to speak. So which bones break? Technically speaking, any bone in your body is at risk for having a fragility fracture, but there are some bones, some areas of your body that are more common than others. The first one of those is in the spine. These are called vertebral compression fractures when you get these. So you can see the picture of the spine there, the vertebral bodies, those are the building blocks. You can think of them stacking on top of each other, kind of one at a time. So here's one here, you can see where my mouse is. Second one is here. Third one is here. These little blue guys in between, those represent the discs, kind of the cushion in the spine. You can see that middle vertebral body there. You can see the cracks that are going across. Suddenly, a vertebral body that should look like a nice rectangle looks like a slice of pizza or a slice of pie. It looks like a wedge. That's a classic vertebral compression fracture. And that is, to date, still the most common fragility fracture that we see in the United States. Hip fractures, the next one there, are a close second, and that may alternate back and forth here with the new numbers soon, but so far spine is still the number one. But number two, like I say, is very close. Those are the hip fractures. There we go. That means proximal femur fractures, okay? That's what we mean when we say hip fractures and fragility fractures. It's the proximal femur, which is the thigh bone here, the ball portion of the ball and socket joint of the hip, okay? You can also, however, have fractures on the other side of the hip joint, which is called the acetabulum. That's the cup side of the hip joint, but that's a different beast. That's actually a fracture of the pelvis, okay? But you can have fractures of the pelvis that are, in fact, fragility fractures. All right, let's see. We are not advancing like I would like here. There we go. So that's what we see there, fractures around the actual pelvis bone side of things as opposed to the proximal femur, okay? You can have fractures down by the wrist, in the distal radius, and the distal ulna. This guy's not quite advancing like it needs to. I don't know if it's a delay or what's going on here.
It might be a delay.
All right, let's see here. All right, guys. Yep, still not going. Let's see. Let's see if we can do it on this one. Not going either.
When you click, does it? Or
Yep, tried both and tried the little hand guy here. Yeah, not quite going. Sorry, guys, technical difficulties. Hang tight. Back one. Go forward. Yeah. All right, hang on. So I'm glad you guys are here. I wonder if this died. Technical difficulties. Hang tight, everybody.
We'll continue in just a second. Just give us a minute. We are trying to get our PowerPoint back up and running.
There it is. Okay. This way. That was great. Okay.
okay,
Okay. Yeah. Perfect. All right. I'm just gonna leave that off.
All right, I'm just gonna touch those two buttons then.
Okay, all right, crisis averted. All right, we're back. I hope. All right. Down at the wrist. So down at the wrist, there are two main bones. Those are the radius and the ulna. They have to originate up at your elbow and come all the way down to your wrist. It's the radius bone, the thumb side bone, that is the most common that breaks down there, but certainly the ulna is not far behind. Also, the shoulder or proximal humerus is another common place for these fragility fractures to occur, as are down at the distal tibia and fibula, down at the ankle joint, basically, okay? There are multiple different patterns down there. Again, any bone, technically speaking, can have a fragility fracture, and there's certainly other fractures and other fracture patterns that we see, but these are by far and away the most common, all right? And just how common are these? They're very, very common, and that's why we're here, right? So take a look at this. 50% of women and 25% of men, so this is not just something that affects ladies in the room and the audience at home, this is everybody, will have at least one fragility fracture in their lifetime, okay? And that's all comers. We're not taking into account age or anything else beyond the age of 50, okay? That's everybody. If you actually look at the number of people with diagnosed osteoporosis, and so this is going to be a low ball number because how many people are walking around in the community without osteoporosis, or with osteoporosis but without a diagnosis, you can see those numbers increase significantly. It bumps up to 65% of women and 40% of men will have at least one of these things. So could be you have a spine fracture, then a hip fracture after that, then a proximal humerus fracture after that, okay? Just having one doesn't mean you can't have another in your lifetime. So they're very, very common. Overall, men in particular have a lifetime risk. So starting from teeny tiny baby going all the way through the day she'll leave this planet, they have a lifetime risk of a fragility fracture of 27%. that's more than double the risk of developing prostate cancer. We give prostate cancer a lot of press and a lot of buzz. There's a whole month that's dedicated to men's health, with prostate cancer being a big part of that. And the fragility fracture risk is more than double that in the lifetime. It doesn't get quite as much press, so it's still a pretty big risk thing to think about, okay?
My grandpa had that.
Prostate cancer or fragility fracture? Yeah, it is a common thing, but fragility fractures are more than double that, and that's just for the gentlemen. So it's a very common thing. If you actually look at the nationwide and worldwide numbers for this, so look at the United States and then globally, the numbers are even a lot more staggering. So there are more than 2 million fragility fractures per year, and that's here in the United States. There's over 9 million worldwide. Okay, those numbers are increasing. It's estimated to be more than 3 million fragility fractures a year by 2025, and that's just a couple years right around the corner. We're not very far from that. In the 10 years that kind of come between 2016, which is where some of our older data stopped, and 2025, which is the estimated endpoint, looks like we're going to be spending at least $228 billion just on fragility fractures. That's once you get the fragility fracture and moving forward, okay? That doesn't cover any preventative care or anything else that we're going to talk about. And if we prevent just 5% of those fragility fractures, we can save almost $275 million per year, okay? So that's a big chunk of change. That's right up there with a lot of the numbers that we see with diabetes and complications, heart attacks, strokes, that kind of thing, okay? You can see there if we prevent 20% of fragility fractures, we can save over $1 billion every year. So it's a big deal to our whole healthcare system. And again, the numbers worldwide are much bigger than that. Who's getting these? Well, women and men over the age of 45, with very rare exception. There are some patients who end up having some syndromes from birth that put them at higher risk for fragility fractures. But for the most part, it's men and women over the age of about 45 to 50 years, okay? Does tend to affect women slightly more than men, so that's a 60% to 40% split, okay? But it's not zero for men by any means. If you look at the fracture rates versus our national average, you can see that there is a little bit of a split there depending on what your background is. You can see there that the Native American population, that's all comers throughout the entire United States, kind of no matter what tribe you identify with, as well as Caucasians, we're on the higher end. We're higher than the national average for fragility fracture rates. African Americans, Asians, and actually Hispanics tend to be lower. These numbers always fluctuate a little bit, but over the last 5 or 6 years, these have been pretty consistent. Okay, so some people are a little bit more at risk or a little less at risk, depending on their racial background. So that's fragility fractures. Now that we have kind of a basic understanding of what bones we're talking about and kind of who's at risk, we need to talk about the other component of that. That's that second little mark on the goals slide that was right at the beginning there. And that's osteoporosis, okay? Make sure we know exactly what that is, what we're talking about. So what the heck is osteoporosis? It's a term that's thrown around. You need to check your risk. Should we be doing something about osteoporosis? But what actually is it? What does it mean? It is a decrease in bone mass, the bone density, and a disrupted bony microarchitecture. Basically, that means not only do you have less bone than the 30 or 20-year-old walking around next to you, but the bone is also weaker, okay? So it's not just the total amount of bone that you have, but what you have isn't as strong, okay? The architecture, as we look under the microscope, and you can even see a little bit there on that picture that we've got, it's just there's not as much bone, but also the inner architecture on the inside of the bone deep to the cortex is different. It's not as strong. It is on a continuum with osteopenia, okay? So if you want to think of the gray scale as it is, right, on one side you have normal bone, let's say, and on the other end of the scale you have osteoporosis. Osteopenia is that gray zone in the middle where your bone is not normal, but it's also not so badly deteriorated that we can classified as osteoporosis, okay? But it's all on a gray scale. Most commonly, Osteoporosis is a result of advancing age, so getting older, it happens to all of us, menopause, and metabolic abnormalities, okay? But there are a lot of things that play into our bone health and our bone access within our bodies, and so there are a lot of things outside of this that can affect our bones. Approximately 10 million Americans right now currently carry a diagnosis of osteoporosis, okay? That's a lot less than the number who actually have it, all right? We're talking about people who have been diagnosed with osteoporosis, not people who are walking around in the community who do have osteoporosis but just don't know it yet, okay? An additional 34 million have osteopenia, okay? Overall, again, you can see the male-female ratio there. This tends to affect women on average more so than men if you take everybody in a group together. But there are, in fact, different kinds of osteoporosis, okay? Who knew? Osteoporosis is just not one big catch-all for everybody. Like I said, there are many things that affect bone health. And so there are now different subtypes, different classifications of osteoporosis. The three main types, again, you can have subtypes and get into the very nitty-gritty of all this, but the three main subtypes of osteoporosis are postmenopausal, senile, and secondary. So postmenopausal is obviously after you've gone through menopause. That tends to be women in between the age of 50 to 70, okay, is who gets grouped into that postmenopausal area. Senile is anybody over 70. And then secondary is the group where, okay, it's not going through menopause and it's not just your age. There's something else that is contributing to an overall poor bone health. If you look at that next point there, men account for 60% of cases of secondary osteoporosis, okay? So, which is kind of shocking. You would think that we as the ladies in the audience would kind of keep up and we would be the highest in each of these categories, but the guys take the cake for secondary osteoporosis. That's where they get the majority of their weakening of the bones, okay? And just to make things fun, you can have more than one type. So you can have all three of those combined together. You can have effects of postmenopausal osteoporosis, senile osteoporosis, and secondary all lumped together, okay, to affect your bones. So these all don't occur in isolation. Again, there's kind of a gray scale or a Venn diagram, if you want to think of it that way, between all these different kinds of osteoporosis. This is a chart that we tend to start learning as presidents and interns for all of our exams. This is a very, very, very abbreviated version of that chart. I just wanted to give you a kind of flavor of all of the different things that can come in and affect osteoporosis. Okay, I'm going to highlight a couple of these just to show you how varied things are. This is by no means an exhaustive list of this, okay? But you can see across the top, there's lifestyle and family history, there's medications, there's some genetic components that play into this, of course, and then there are disease states, things that are happening in other parts of your body that affects the bony axis. So if we look at these, just a couple to kind of note, having a sedentary lifestyle, that's huge. Not getting up and even doing routine walking or weight-bearing exercise has a huge influence on your bone health. Tobacco use, heavy alcohol use, just a poor overall diet and malnutrition has a major influence on how strong your bones are. As we move over onto the medication side of things, a couple that you may not think of right off of the bat as being important. Omeprazole, Prilosec. How many people take that for heartburn, particularly on a regular basis? That affects your GI tract and how you absorb some nutrients. Long-term use of that has significant effect on how healthy your bones are, how you absorb calcium and vitamin D. The next one down is furosemide or Lasix. That's the common water pill that people can be on that have heart, lung, or kidney issues. That affects how your kidneys handle calcium and vitamin D. So it has a massive effect there. SSRIs, selective serotonin reuptake inhibitors, one of the most common antidepressant medication classes. But you can see the list, the list goes on and on and on. We'd be here for a whole day going over every single medication. Genetics we'll skip over for a little bit. There's some nitty-gritty things there. But over in the disease states, some of the most common things that we see with patients on a routine daily basis, some of the most common things that come into your primary care doctor's office or even the emergency room. Patients who have renal failure, kidney disease, diabetes, type 1 and type 2, COPD, liver failure, rheumatoid arthritis, any inflammatory state can affect just that significant inflammatory profile that's there consistently in your bloodstream affects how you absorb everything, and calcium and vitamin D are part of that. Your bone health is part of that. So there's a lot that can influence over years to decades just how strong and healthy, or not strong and not healthy, your bones are, okay? Well, how do I know if I have osteoporosis? This is a little bit of a moving target, I will be honest, so I'll mention that right off the bat. If you ever have a fragility fracture, or if any of your friends or family ever have a diagnosed fragility fracture, you by definition have osteoporosis, okay? It's kind of like Monopoly. You do not pass go, you do not collect $200. If you have a fragility fracture, you by definition have osteoporosis, okay? The DEXA scan is still the testing modality of choice for osteoporosis right now for multiple reasons. Now, people are working on other ways to do this, other markers that we can use, other kinds of imaging modalities. That's kind of the on the horizon little blip there, looking at some bone turnover markers in just routine blood work, looking at your bone density, not so much through this DEXA scan, which I'll show you what that is and talk about that a bit, but looking through CAT scans, high resolution MRIs, even looking at areas of the body beyond just the spine and the hip, which is what the DEXA scan itself looks at. But a lot of those things that are on the horizon area, they're not really ready for prime time yet, meaning people are researching them and they're looking at them and looking into them, but we don't have the perfect data to be able to take them mainstream for all of the primary care doctors, for all of the emergency room physicians, the internal medicine doctors, orthopedic surgeons, to be able to look at those and say, hey, I have these numbers, and here's what I should do with them. We can get the numbers now, we can get the data right now, but what we do with it, that's the work that's being done. So right now, still the imaging modality of choice for osteoporosis is the DEXA scan, which is a specialized set of x-rays that measure your bone density at your lumbar spine. Remember, we said spine is the #1 area for fragility fractures, and at the proximal femur up at the hip, and that's the #2 area. So that's why those two places have been routinely targeted with the DEXA scan, okay? Scores are compiled from multiple vertebral bodies. It's usually L2 through L4, with some exceptions, and multiple areas around the hip. And then together, that's how you get your actual DEXA, okay? This is, if you look at that little kind of blue and white guy there, that's an iteration of a DEXA scanner. They all look a little bit different depending on what company it is, but that's about what it is. And the DEXA scan itself, then you get 3 numbers that are generated, okay? And these are the ones that we all look at from the physician side of things. So the first is just your bone mineral density, the actual number, okay? But even more important than that, it gets parceled out into what's called your T-score and your Z-score, okay? And the T-score is the most important one that we pay attention to. That is your bone mineral density matched up against 30-year-old control patients. So it doesn't matter if you're 95 or if you're 55 or somewhere in between, your T-score is generated with your bone mineral density on top, based across and compared to a cohort of 30-year-old normal patients, since our bone density tends to peak somewhere around 30 years of age, okay? Your Z-score is you against age match control. So it's a little bit of a fairer fight, so to speak, as far as the number goes. But most of the data, most of the clinical trials, et cetera, that are done within the osteoporosis medicines, tracking patients long-term, they're all done based on the T-score. So the T-score tends to be the most important thing to keep track of, okay? And as you look at your T-score, if you're looking for osteopenia diagnosis, there's your range there from a -1 to a -2.5. Anything less than a -2.5. So whether you're -3, -5, -25, hope we don't get there, that is considered osteoporosis, okay? Okay, so now I know my T-score, fantastic. I have a number, I can talk about at dinner parties, but do we actually do anything with that T-score? And the answer is yes. We can do a lot with it, and one of the ways that we use that T-score is through something called the fracture assessment tool. This was actually developed in the UK and then went worldwide. It's a way to look at not just your height, weight, and your T-score, but to incorporate some aspects of your medical history together with some of your own fracture history, your family fracture history, your lifestyle, and look at, hey, what is your actual risk of having a fragility fracture in the near future? And it can also help us kind of guide treatment options and suggestions for patients, okay? So this is what it looks at. All of these little points here are what get into the FRAC system. It's age, sex, weight, height. You guys can all read those. You don't need me to rattle them off to you. But you can see even with that long list, there are a lot of things in that table that I had up just recently, that yellow and white table, that are not included on here, okay? So that's where, you know, using this FRAC score can get us into a touch of trouble. The results from the FRACs calculation give you a 10-year risk for a major fragility fracture, all comers. So that means spine, that means proximal humerus, that means wrist, that means ankle, but it also gives you a 10-year risk for a hip fracture, okay? And based on where you fall in these groups, particularly for the 10-year, any major fragility fracture risk, that really helps us dictate and guide, hey, is this somebody that we can do some weight-bearing exercise and some dietary intervention with, or is this somebody who's on the other end of the spectrum who really needs some of the more advanced osteoporosis medicines that are out on the market, and anywhere in between that, okay? But like I said, that list of what the FRACs looks at, this list right here, is definitely in no way, shape, or form long enough to look at every single little detailed component of the basically bone axis on the inside of our body. It would take us days to sit there and go through all of that with each patient. And so unfortunately, using the FRAC system can underestimate your fracture risk if you are at particularly high risk. If you have not only diabetes, but rheumatoid arthritis and lupus, and you have kidney failure from your diabetes, and you have liver failure, and you have a very sedentary lifestyle, the FRAC system may not calculate how high your risk truly is. It may underestimate it, okay? Okay, that is the first half of the talk. I know that's already a lot, kind of overwhelming. This brings us to the second half of the talk, which are those two questions at that first slide that I presented. So what does it mean to have a fragility fracture? If you get one of these things, what does recovery look like? But more importantly, what effects do these have on life long term? Okay, so I broke a bone. Who cares? Is the other way I name this part of the talk. Let's take a look at this. At age 50, a woman has the same risk of dying from a hip fracture as she does from breast cancer, starting at age 50. And we may even be actually moving this rope a little bit down to age 45 as opposed to 50. Okay, that's a pretty sobering statement to think about, right? Breast cancer is very prevalent. It's something that is on our minds all the time, whether it's for ourselves or for family or friends. And we have the same risk of a hip fracture taking either ourselves or our loved ones, you know, away from us as breast cancer. Yeah, it's pretty big. Women over the age of 45 spend more time in the hospital for osteoporosis, aka for fragility fractures, than breast cancer, diabetes, or myocardial infarction, which is heart attacks, which also is surprising. That was actually surprising even to me when I looked at the data for that. But it's a significant burden on the hospital system, but also it's a significant amount of time in the hospital, okay? This is a slide that I'd like to spend a touch of time on. We have a lot of data about hip fractures and how people do after having a hip fragility fracture and their recovery. This is where some of our best data for fragility fractures comes through to us. And one of the things that we tend to focus on from a surgery standpoint, which is where I usually come in and meet my patients with fragility fractures, is how patients do long-term and their outcomes. And this is something that has been sobering for many decades for all of us in orthopedics and continues to be, because we're not getting any better at this. We're actually getting worse. This is the current hip fracture mortality data, meaning the death data around hip fractures. Okay, I'm going to go through this bit by bit because I think it's that important. In hospital mortality, that means patients who die in the hospital at the same admission, who never make it out. They come in with a hip fracture through the emergency room and never make it out of the hospital, not even to rehab or a skilled nursing facility. It's somewhere between 1% and 5%. Okay, that number fluctuates a little bit as you look at exactly the details of what kind of hip fracture we're looking at and how long it took to be able to get the patient to surgery, that kind of thing. But if you look at the higher end of that, 5% of patients, that's 1 in every 20 hip fractures that comes into the hospital, 1 in every 20 patients doesn't make it out of the hospital with their life. And I can tell you just across the street here at TMC, we do, I would say, at least 20 hip fractures within a 7 to 10 day period. So these are very, very common over there, okay? And to have just that number alone is very sobering, okay? If you go the next line down, that's mortality or death within 30 days of having the hip fracture, okay? You can see the number jumps up there somewhere between 5 to 15%. That's not a small number. So that means you may make it through your hospital stay and get through your first couple weeks of either being at home or being at a rehab facility or in a skilled nursing facility, but don't make it beyond that, okay? The last line there is the mortality data at a year. So a whole 1 year anniversary from the date of the hip fracture actually occurring. And that's somewhere between 25 and 35%. So that's somewhere between a quarter to a third at least of hip fracture patients are no longer with us and are no longer with their friends and their family, okay? Believe it or not, that number is actually higher for men who have hip fractures. So it's up above 35% now, okay? So the mortality data is actually worse for men as opposed to women, all right? But what does life look like after fragility fracture? If ourselves or our friends, family, loved ones actually do not become part of the statistics from that last slide and actually do make it through hip fracture recovery and survive, does everybody get back to normal? And the answer to that is unfortunately no. Even for the patients who have the absolute most perfect on-track recovery, you take all hip fractures, all comers, and there's also some pretty sobering lifestyle data that we have now, and that's what I'm going to share with you in the next few slides here. So hip fracture morbidity data. So less than half of hip fracture patients, again, this is all comers, less than half of those patients return to their previous standard of living, okay? That means where you live, who you live with, what kind of help you need to have at home, how you're able to take care of yourself, all right? Half of hip fracture patients aren't able to go back to, at least half, are unable to go back to their previous home where they live. So this means families having to sell the family house, move into assisted living. If you were in your own apartment in assisted living, it means going over to the other side of the building in skilled, okay, like in a nursing home type care. It means not being able to have the strength or the coordination to drive a car anymore. So you have to have someone take you to all your appointments, do all of your errands for you, or have someone take you to do those, okay? Not doing some of the activities that you love to do, particularly things that are higher impact, longer bike rides, longer walks, taking the dog out for that 2-mile walk up Sabino Canyon isn't a thing that you can do anymore, okay? Same thing with previous levels of ambulation. These things are tied together. So again, less than half of hip fracture patients return to their previous level of ambulation. And that doesn't just mean distance or time out on a walk in the morning. That means what you have to use to help yourself get around. So less than half of patients who are up walking on their own, no cane, no crutch, no walking stick, no walker, no wheelchair, less than half of those patients are able to, at a year plus out, be back to using nothing at all. Most people kind of drop a level, as we say. So if you didn't need anything before the hip fracture, suddenly you're reliant on a cane, even though you have rehabbed perfectly. Your fracture has healed in, you've done everything you're supposed to do, and clinically you're doing awesome. You still have to use a cane for the rest of your life. If you were on a cane going into the hip fracture, you may be fully reliant on a walker or wheelchair afterwards, okay? It's that dramatic. Some more sobering fracture data here. Again, I won't get into too much of the nitty gritty because I want to keep us on track here. But as you look at the Medicare data that gets released here every cycle or so, the last data that we have, there were 2.1 million fragility fractures in the 1.8 million Medicare beneficiaries that were tracked. The patients that did have fragility fractures were 300% more likely to have another one as opposed to the registrants who were kind of having their first one. So once you have one fragility fracture, it's kind of a slippery slope to developing a second, a third, a fourth, okay? There's a 15% refracture rate. Compression fractures, you can see the data there. If you have a compression fracture going in, you are 5 times more likely to have either another compression fracture or a hip fracture on top of it within the same year. Okay, so kind of do an insult to injury. And again, overall, a 30% hip fracture mortality is what they reported. And again, those numbers keep continuously going up and up and up. We're not getting any better with that. We're getting worse, unfortunately. All right, that brings us to the last little bit. Sorry for all of that doom and gloom part of the talk there. But okay, I get it. I'm drinking the Kool-Aid a little bit. I get that fragility fractures are a bad thing, but let's be honest, is there anything that can be done to help prevent one, either myself or friends or family? Is there anything that we can do at this point, or is this just a black cloud that's going to hang over my head? The answer to that is yes, there are things that we can do, but the most basic, and I say this a little bit tongue-in-cheek, is don't fall. Okay? And I know that's, everybody should be rolling their eyes at me at this point and going, oh, for heaven's sake, are you kidding me? That's all I came here to listen to is don't fall. But this is the most important thing that we can influence, okay? We're never going to be able in anybody to either get you back to totally normal bone like what you had when you were in your 20s, and we're never going to be able to keep those patients who are in their 20s, 30s, early 40s now at the perfect level of bone. Everybody is going to develop a weakening of the bone over time as we age, whether that gets to osteopenia or goes to full-blown osteoporosis. So not falling, not giving your body that impact strike is actually the biggest thing that we can do from a prevention standpoint, okay? 33% of patients over the age of 65 fall at least once a year. And again, this isn't a dramatic fall. This isn't you tumbling down the side of the Grand Canyon. This is not something major, massive, okay? This is a trip in the kitchen. This is misstep on that rug coming out of the bathtub or the shower and coming against the bathroom floor. Common everyday stuff, okay? Those are the falls, trip slips that we're talking about. And it only takes the one to give you your first fragility fracture, right? And kind of start down that terrible spiral. Things that you can do to prevent falling. They all seem like basics, but once you have a fragility fracture, in hindsight, it's, oh, why didn't I move that rug? Why didn't I take care of that flagstone in the yard that I have been tripping on for the last 5 years? Because that's what brought me into the ER this time. But those are, you guys can read all of those. You don't need me to read them all off for you, but the loose rugs, the carpet edges, things that you know that you trip over in the house, get rid of them or move them or put weights on the rug, do something to prevent those from being that same tripping hazard again and again and again. Dogs, kids, grandkids, train them to not be underfoot. If they're always kind of running in between your legs, you're tripping on the cat at 2 o'clock in the morning every time you get up, do something about that now, okay, not later. Again, out in the yard, places where you love to be around the house, make sure those tripping hazards are gone too. People trip inside and outside the house, in the garage, going down the street to the mailbox, okay? Making sure banisters are installed in the house where you need them. They make all kinds of zhuzhy and very fancy bars for the bathrooms and showers and all of that. Go for it. Have them installed now, not later, okay? Things like night lights, no slit mats. Again, we've come leaps and bounds from just the one kind that you can find, you know, at Bed Bath & Beyond. There's whole catalogs now that are devoted to that kind of stuff. So get the thing that will go with your house, something that you love to look at, not something that makes you feel like you're in a hospital, but in your own house, okay? Wearing appropriate shoes with good tread, even in the house. Where I came from for my residency program, again, I was in Northeast Ohio, 9 months out of the year. There's ice, there's rain, there's mud, there's all kinds of things that you can trip and slip on. And it was always make sure you have good shoes, good winter boots, you know, when you're outside the house. Same thing applies inside the house, whether you live back in Ohio or upstate New York, or you live here where we don't get snow, right? You want to make sure that you're not slipping on that slick tile that's in the house, the concrete floors that you have, that kind of thing. Using a cane, walker, walking sticks when you need them. I know some people get self-conscious about them and don't want to use them or don't want to use them out in public and be seen with them. again, it's not worth the risk, okay? But the most important thing that I can recommend for you more than anything else is actually balance training and physical therapy. So I will tell you, it's at least half of my hip fracture patients that I treat and that I see after the fact. It'll either be the patient or a close family member or friend who says, oh my gosh, Sally has been worried about her balance for years, or mom's been just kind of really unstable and unsteady. We've just watched it get worse, and now we've got a hip fracture to deal with. I wish we had done something beforehand to make this better. There are fall training programs, there's balance training, there are ways to get stronger with how you walk, how you sit, how you stand, how you carry yourself, and literally train you how to fall safely, but not on an actual floor with, the big puffy bean bags and things like that. So when you fall, you're not reaching with that outstretched hand and breaking your wrist and breaking your shoulder. You are tucking and kind of rolling appropriately to prevent as much damage as you can. If you feel like you need one of those programs, don't be quiet about it. Talk to your primary care doctor, come in and see the orthopedic surgeon that you normally see for your carpal tunnel or your low back pain, or me, and say, hey, getting into physical therapy is something I feel like I need to do. My balance is off. I don't feel steady on my feet. It breaks my heart when after the fact, people say, I wish I had done something and I didn't know where to start. This is where you start, with getting stronger and being able to just be better with walking and falling. Believe it or not, simple as that sounds. So preventing fragility fractures also is about kind of managing your osteoporosis as best you can and preventing that slide from osteopenia into osteoporosis as much as you can. Some of that is exercise, okay? And everybody's looked at, does it matter if you do this on your own, in a group, in a formal program, through YouTube? It really does not matter. You can do this however is convenient and most comfortable for you to be out and exercise. If you want to do it in a group with friends, excellent. You want to do this on your own, excellent. You want to go to the gym and be part of a Silver Sneakers program or the equivalent, great, do that. There are plenty of DVDs and VHSs for things that you can do in your house in the comfort of your own home, particularly if the weather's bad outside and you don't want to go outside for your daily walk. Have something else that you can do at home inside that's convenient for you. Or when it's 115 degrees here, also don't want to be outside in that. But the biggest parts of that are make sure there's some strength training involved. Some part of aerobic training doesn't have to be every day, but getting your heart rate up at least a couple times a week is very important. And again, that balance and core, making sure that you are stable and steady on your feet when you're up and moving around. This little diagram here, this Too Fit to Fall or Fracture program, is actually out of Canada, but it's one of my resident friends who's back up in Canada now and practicing sent me that a couple years ago. But that's their program up there. There are equivalents through our programs down here in the US. Again, Silver Sneakers is kind of the most popularized one. But it's all about, again, you can see their balance exercises, strength training, aerobic physical activity, all of those nice little highlights put together. Okay. Good diet is a mainstay, okay? And that means in the most basic of terms, making sure that you have a good protein source. I always recommend something about the size of your fist, give or take, once a day. Doesn't really matter where that protein comes from, as long as it's from a good source, okay? So as, little antibiotic, GMO, pasture raised, kind of is the best quality that you can and that you can afford, get that. But whether it's beef, chicken, fish, etc., it doesn't matter where you get it from, as long as it's a good protein source of some kind. Having some calcium and vitamin D, of course, is always excellent. Whether you get that through supplements, through milk, cheese, ice cream, doesn't really matter. Again, dietary sources are usually absorbed a little bit easier and a little bit better than just taking everything in the form of a pill. I happen to like the ice cream version of things, but to each their own. Having some fish or fish oil, if the taste of fish is just not something you like, actually does help, again, with that absorption, particularly of the vitamin D in your system. Having some vegetables, everybody says, eat your veggies. That's very true. Limiting liver is the one part of bone health from a dietary standpoint that I wanted to mention. Having a really high amount of liver in your diet no matter what form, can interfere a lot with your calcium and your vitamin D absorption. So if you tend to like to eat liver 3 times a week, maybe ratchet that back a little bit and find a different protein source. Check the DEXA scan. We already talked about there are other ways of looking at osteoporosis now, but a lot of them are not fully mainstream and live yet. So DEXA is still kind of the primary way of checking whether or not you already have that diagnosis of osteoporosis. Technically, the National Osteoporosis Foundation recommends average risk between the ages of about 65 for women and 70 for men is when you should start. However, there are a lot of exceptions to that average risk rule. And most people, if not all people, to be very honest, have at least one of those exceptions, okay? And so most people are starting to get DEXAs approved around the age of 50, okay? So if you haven't had one yet under your belt and you're age 50 or older, I'd recommend it, if nothing more than to get a baseline of where you're at right now, okay? Blood work, same thing. So we talked about how there are a lot of influences around bone health and the bone axis on the insides of our body. So even if we can't track those fancy bone turnover markers and things like that to actually diagnose osteoporosis, there are some basic blips on routine blood work that your primary care doctor probably already runs at your yearly checkup that can be looked at in between your what's called your BMP or your CMP, your metabolic panels. Your calcium, vitamin D levels, and actually your thyroid and your parathyroid levels should be managed and checked. If there's any major abnormalities on that lab work, those are things that should be fixed, okay, kind of sooner rather than later. That helps dictate whether supplements or medications are needed, and certainly all those secondary osteoporosis risk factors, smoking, heavy drinking, making sure diabetes, rheumatoid arthritis, all of that is under control. Are always good things to keep on track with as well. Kind of managing chronic medical conditions is a big deal with your overall bone health. Well, since we brought up calcium and vitamin D, this is a question I get a lot, so I figured I'd just put it out there. How much do I actually need? How much supplementation should I be taking? This is a lovely little diagram that I stole from a paper from Johns Hopkins. It was already so pretty that I decided just to include it here, okay? So this is recommended daily allowance, or RDAs, of calcium, and then your max, those are the first 2 columns there, and then vitamin D, same thing, recommended international units and the max there. It goes by how old you are and then separates a little bit down at the end of that in male and female. You can see if you're in between about 19 and 50, what you need. You need about 1,000 milligrams of calcium and about 600 international units of vitamin D, okay? As we go further on down here, once you get beyond 50, the numbers separate just a little bit. The vitamin D remains the same, but your calcium levels, whether you're male or female, fluctuate just a little bit. Guys stay the same. Ladies, we jump up a little bit just by 200 milligrams. And then once you get above 70, everybody kind of comes together yet again. The 1,200 milligrams of calcium for everybody. And then we jump up a little bit with vitamin D. But these are guidelines, okay? So what I tell everybody is this is a place to start, okay? If your calcium and your vitamin D numbers look good on that routine blood work that I just mentioned, then probably sticking with the recommended daily allowance is a good thing for you, okay? But if your calcium and vitamin D are low, just sticking to the RDA may not be enough. Sometimes people need higher doses. Sometimes people need infusions of these things, okay? We've all heard of people needing to be on iron for anemia. You may have friends or family that have had that. Iron comes in the form of dietary supplementation, so just making sure you eat iron-rich foods, and sometimes that's all people need. Some people need iron in the form of pills. Some people have to come into the hospital for infusions. Same is true for calcium and vitamin D, okay? There's a spectrum of how much you need, so it's not just looking at a chart and kind of saying, okay, here's where I am on that chart, here's what I need, and that's all I should think about, okay? Last but not least, osteoporosis medicines. Okay, this is another kind of hot topic, and again, we're kind of seeing the forest and not every individual tree here. We could spend multiple hours talking about the ins and outs of all these different medications. But in a kind of basic way to think about these, they're the anti-resorptive medications, so bones medications, the way that they work on the bones is to prevent you from resorbing the bone that you have, okay, from breaking it down. The first big round of medications to come out on the market were the bisphosphonates, so things like Fosamax, Beniva, and Reclass. Those are the ones that started kicking into gear in the 80s and 90s. That's how they act. Also, Prolia is another one that follows in that category. It's an antibody, but it's still an anti-resorptive. The other and a major class is the anabolic agents. Okay, those are medications that work to kind of kick up your bone-making cells, your osteoblasts, to kind of wake those cells back up and have them lay down more bone than they maybe otherwise under normal circumstances would, okay? Forteo, Tymlos, and Evenity are the three most common of those on the market right now. Evenity is, again, another kind of antibody that's used, and the Forteo and Tymlos are actually a equivalent of parathyroid hormone. And we talked about checking your thyroid hormone and your parathyroid hormone levels. Thyroid is a big influence on keeping your bones healthy, kind of where you are on the scale of how much bone you're making versus how much bone you're resorbing, which is a natural process in our bodies, but can get tipped kind of abnormally one side or the other. And the Forteo and the Tymlos work on that axis. There are risks and there are benefits with all of these medications, okay? And just because your best friend had a great time on Fosamax doesn't mean that that is the ideal medication for you. Just because your best friend had a bad reaction with Fosamax and got changed to Tymlos doesn't mean that Fosamax is terrible and is an absolutely horrible drug and that everybody should automatically be on Tymlos, okay? It's a very, very, very specific set of criteria for who's appropriate for each of these medications. So it looks at all of your chronic health issues. It looks at your height, your weight, how many fractures you've had, if any. All of those things play into which medication is most appropriate for you, okay? And so that is a long talk with a primary care doctor or coming in to see an endocrinologist or someone who really truly specializes in bone health to have that full medical history, full long talk of what are the real risks, what are the benefits with all of these, and where am I likely to get the most bang for my buck from a risk perspective, okay? Okay, so in summary, we're almost done here, guys. Thanks for bearing with me. So fragility fractures are common and they're life-changing. Whether you get one of these things yourself or it's a best friend, family member, these things can change your life, particularly the spine, and you've seen all of the morbidity and mortality data for the hip fractures. These are serious business, okay? Everybody's at risk for these at some point in their life, and that risk begins at a lot younger age than people think. We're not talking about just patients in their 80s and 90s and beyond. We're talking about people who are 50 and beyond, and again, that rope is being marched younger and younger as we get through our data. It's going to be 45 or even 40 here in the upcoming decade, okay? Prevention is the most important thing. If you can keep yourself from having one of these fragility fractures, I promise you it will be worth it. And even if it's little changes that you have to your exercise program, to where that finicky rug or flagstone is, getting the dog trained so he doesn't dart out in front of you every time he goes outside, all of those things help. And don't neglect your overall health. All of those chronic medical conditions will play into your bone health long term. And of course, don't fall. All right, that is it, ladies and gents. So I think we're gonna switch over to questions now, right?
Yes.
Okay.
You covered so much information, and so I don't have a whole lot of questions, but I have a few. Can you just describe again where you're at most risk of having a fragility fracture besides the hip? Like, what would the numbers? I know you said.
So the question was where are the most common places to have these fragility fractures outside of a hip fracture? So when you look at the numbers, still the highest numbers are in spine, those compression fractures, where you go from the rectangular vertebral body to the pizza slice or the wedge. Those are still, from just sheer quantity, the number of fragility fractures that are counted every year. Vertebral compression fractures take the vast majority of those. Hip fractures are very close behind that. And in fact, there have been a couple of years in the past, probably 8 or 10 collection years that we've had now, where they've actually flip-flopped, where hip fractures have gone above fragility, or hip fractures have gone above compression fractures, and then gone back and forth and flip-flopped. But on average, you take all the data, the spine fractures still win. Hip fractures are a close second, and then coming down into the distal radius, so the wrist fractures are third, usually followed by shoulder fractures, proximal humerus.
Okay, great. And to prevent maybe a refracture, is the best thing to do to look at sort of an exercise program, or I know you were talking a lot about exercise for preventative measure.
Absolutely. So the question was, once you have a fragility fracture, what's kind of the best way of preventing another one? And it's what I kind of lovingly term the kitchen sink approach once you have one of these. So first and foremost, you want that first fragility fracture you have, whatever it is, whether it was a hip fracture, a wrist fracture, a shoulder fracture, whether it needed surgery or not. Some of these can heal in on their own, particularly the wrist fractures and shoulder fractures. You have to operate on every single one of those. But to get that to heal in first and foremost and heal in properly is sometimes just half the battle, okay? Preventing infections, preventing pneumonias and all the other accoutrements that come with recovering from a major fracture. But it's also making sure that your therapy afterwards is adequate. So making sure you're not just rehabbing that one part of your body that had the fracture in it, but making sure you're getting that kind of stem to stern total body rehab. You have work on your gait, you have work on your balance, you have overall work on stretching and strengthening. You start having a little bit of more weight-bearing exercise, long walks, something like that added to your regimen. And then making sure, again, that you follow through with things like your diet, calcium, vitamin D, all of that. If one of those bits are missed, then you're not going to not only rehab your current fracture as well, but you're also not going to prevent fractures in the future as well as you could have. So it's a combined approach with everything. Yeah.
Great, thank you. My last thing is I just want to put up for everyone, if they're interested in an appointment with you, Dr. Patti,
Yes.
the appointment, to make an appointment through Tucson Orthopaedic Institute over on the east side location. The number is 520-784-6200. So I want to thank you so much for being here today. I'm going to sign off online and I'll let you continue in person. So
Okay, perfect. Thanks, Maya. All right.
Thank you so much for being here today. We are going to have our next presentation will be on Thursday, and that will be what you need to know about prostate cancer from diagnosis to treatment with Dr. Berry. So please join us on Thursday, September 29th at 2 p.m. Thank you for being here.